This is the Real Health Podcast brought to you by Riordan Clinic. Our mission is to bring you the latest information and top experts in functional and integrative medicine to help you make informed decisions on your path to real health.
Welcome back to another episode of the Real Health Podcast. I am Dr. Drew here at the Wichita campus. We are in another episode of the Riordan Roundtable with my esteemed colleagues, Dr. Stacy Dunn, who is joining us from Kansas City. Hello, Stacy.
Hello.
And then I have Dr. Kirsten West, who is joining us from Castle Rock, Colorado. Kirsten, how are you?
I'm good. How are you guys?
Doing well, thank you.
Good.
So last episode, we kind of just very broadly introduced ourselves, kind of our background, what brought us to Riordan, how this all worked out. And today, I wanted to kind of dive into a little bit more about what the two of you really practice day to day, and that is integrative oncology. So we talked last time about kind of your educational path and how you got into oncology especially, but I want to hear it from your own words. What exactly is integrative oncology? Dr. Dunn, I'd like to start with you.
So it's supporting patients with a cancer diagnosis. I mean, ideally from the moment of diagnosis to through survivorship. It's helping to support them along the entire journey, helping them to fight the cancer, helping to support and offset side effects from any conventional treatment, helping to improve quality of life, and then also just creating an environment and a body that ideally will not will reduce the risk of recurrence down the road. So we're really looking at a lot of markers of, terrain health and health of the body, and just the overall, their patients' overall health to help prevent recurrence and just help improve their overall quality of life.
Yeah, no, I love that. The idea of the terrain has been something that we have talked a lot about over the past year, especially with our cancer care conference that we had back in November, and understanding the idea of what the terrain is, I think it really helps kind of grasp everything that goes into a cancer diagnosis.
Right.
Dr. West, what is your interpretation of integrative oncology? Anything you want to add there?
I think everything Dr. Dunn said is spot on. For me, I also think and I know both of us, it's empowerment, helping the patient to know what it is that they need to do, helping them to see why they're doing what they're doing, giving them the knowledge, really that co-learning piece.
Yeah, I think knowledge is power. Absolutely.
Yeah.
It is really, I think people get so lost in the weeds when you get the diagnosis of cancer. It's the C word, it's a huge word that completely changes your life. And I think so many people get stuck in that area. And it's something that definitely weighs heavily on not just body, but mind and spirit as well.
100%. Absolutely.
Yeah.
So when co-learners, because we don't have patients, we have co-learners. When co-learners come to see you girls, what exactly, what is it that you look at, and what is, some of the tools in your belt? Let me throw it back to Dr. West on this one.
Mm-hmm. The patient. The first thing I think we look at is the patient themselves. Mm-hmm. What makes that person who they are? Everybody has their own journey as to why they're here and why they developed cancer. And so trying to understand more of what that person is bringing to the table is only going to help us help them as doctors and as co-learners together. For some people, stress is, I actually think for everybody, stress is a big deal. Yes. Trauma, poor diet, just numerous things. And so really meeting the patient where they are, I think is thing number one.
Yeah. Dr. Dunn, what is some of the things that you look at as well from the co-learner point of view, but then also some things that you might pull from your own toolbox as far as trying to help whoever's sitting in front of you?
Mm-hmm. Yeah, I agree with Dr. West and trying to meet the patient where they are. So it depends on whether they're in the middle of treatment or not, or whether they just received the diagnosis, or whether they're, they've had their first clear PET scan and they're looking to prevent recurrence. And so it kind of depends on where where they are in the process. But we have lots of great tools, and agree with Dr. West that stress reduction is so whatever tools we can use to help support that. So for me, acupuncture is a big part of that, and herbs could be helpful, and meditation, and daily mindfulness techniques that can be helpful. We love mistletoe and IV vitamin C, and we use ozone therapy, and so we have lots of really great tools that in our toolbox that to support patients as well.
Which we'll get into some of those specific treatments and different things that are out there as far as the trendy things are going, as well as some of the other things that I think are still looked at with a very heavy skeptical eye from the conventional side of medicine, but definitely have a lot of research behind it as to not just how it works, but also why it works. So before we get into that, I think there's kind of a chasm between integrative medicine and conventional medicine. And I think that, again, going back to what we said about, the education aspect of things, education, knowledge is power. So I know both of you have worked in the conventional side of things as well, especially through your education. I mean, just bird's eye view, like we talked about, like, what is your opinion of conventional approach to cancer? Dr. Dunn, let's start with you.
Yeah, I mean, I think we need all hands on deck when it comes to a cancer diagnosis. So I think that those therapies are often needed and necessary, but it is a very limited approach. So there, you can surgically resect a tumor, but then you're still left with kind of all the things that may have led to the growth to begin with, right? And so that's where we come in, and we're like, okay, has blood sugar been imbalanced for a long time? Or are there some toxicities that may have allowed this to grow? Is there mold? Is there, are there nutritional deficiencies? So many things that may have allowed for that tumor to develop in the first place. So, I mean, it's important to get it out, right? And so if surgery is an option, then absolutely. And so I don't think either one of us are against any sort of conventional treatment. And again, cancer it's a tough diagnosis, and so I think that we want to form a team, and so I'm all on board with working with conventional providers, and we've both worked with conventional providers in other settings. I feel like right now it's becoming harder, but historically that's been a very strong relationship for both of us.
Oh, absolutely. I have personally sat in on a couple of Dr. West's appointments, and I've worked very closely with you, Dr. Dunn, as well. And I know your opinions, but the idea here is to get those opinions out to the rest of the world to kind of just see where we all come from and what our approach is. So I think something that you said there is it's all hands on deck. Medicine is a team sport. Absolutely. So I love that. Dr. West, I mean, what is your opinion of the conventional approach to cancer? I mean, what do you like? What do you dislike?
I always think of it as like, you got to get the elephant out of the burning building. Yeah. Get the elephant out of the burning building, and then let's put out the fire. And that's what Dr. Dunn and I do, and many naturopathic oncologists. But I think that we do need conventional medicine, and I wish we could get away, and I'm not sure what terms we would use, but this like dichotomy between conventional medicine or complement. I think the bottom line is that our intent is all the same. Yes. We all want the same thing for the patient. And if we come at it from that facet, we're going to do well by them. And I think that we all need to work together to make that happen. It is a team approach. It takes a village.
Well, and something that I've always said too, something that I kind of just figured out on my own, I guess, in my own journey in medicine, is you practice medicine. There is no just you go do medicine. Like it's not all algorithmic. And once medicine becomes algorithmic, then I feel like you lose the individuality of each and every co-learner that you see. And I love that approach because, to your analogy there, where you have to get the elephant out of the burning building. Great. When you get the elephant out of the burning building, why did the fire start in the first place?
Right.
Was it electrical? Yeah. Was it lightning? Was it? Yeah.
Did someone leave the gas on?
Exactly. So it's these questions that I never really got in medical school in the training. And I think you have this critical thought process. And it's not to say that, we're lacking necessarily. I just think that there's so much you have to learn, and you cannot learn it in like a traditional educational model. A lot of it you have to learn while you're practicing. And that's why it's called practicing medicine. So I think that is a beautiful way of looking at it from both of you, the way you said it. It is a team approach, and everyone has value, and it's not just conventional or integrative. It's just medicine.
It's just medicine.
Yes.
And thanks for bringing up that algorithm piece, because I that is such a big piece of everything we do. And naturopathic doctors can get stuck in that too.
Yeah.
I think it's human nature for us to be like, well, let's box it here. If it's this, then we treat it this way.
Yep.
But we need to remember that it's fluid, and just like every patient is different, every cancer is different.
It's comfortable when it's predictable, and it's not. There's nothing comfortable about cancer. And I would even argue there's nothing comfortable about any disease out there. It's a dis-ease is what that actually is. So yeah, I think so many of us, because of just life and how stressful our society is in general, how the infrastructure of healthcare is obviously lacking in a lot of different ways, not just for the patient, but definitely for the providers as well. I mean, who in their right mind can see 40 some odd people a day and only see them for, on average, 7 minutes at a time, and have everything they need to know in order to make an accurate diagnosis and formulate an appropriate treatment? Like it's impossible. And so it is comfortable to fall back into that algorithm. It's just, unfortunately, you miss a lot. Yeah.
Yeah.
So I threw this question in there kind of as a teaser. I'm sure you both understand that, but from your experience, what therapy improves the overall mortality the most for the patients? I see Dr. Dunn shaking your head. Let's start with you.
I mean, I wish there was one magical therapy. I mean, that's what I would be like. Everyone do this. This is the one thing that will cure all cancer. It's just not that simple, because cancer is not one thing. There's
Right.
not one, and so it's the type of cancer and how aggressive it is and where it is. And so I can't answer that question.
Yeah. Dr. West, what do you think?
I'm going to be really just super bird's eye on this. I think it's returning to our biological rhythm. I think that getting enough sleep, decreasing stress, getting away from processed foods, restoring just everything that our current society has gotten our physiology away from, I think, are the things that are making us sick.
Yeah.
So if we could return to, just being a human being on this earth, I think that in itself could really heal us. And I have this theory, and I don't know if it would even fit now, but looking at epigenetics, Dr. Dunn and I like to look at epigenetics, and so much of it is based on our ancestry of where our ancestors came from. Where did they come from in this world?
Yeah.
Are they Mediterranean? Are they Nordic? Are they African? What? And a lot of our epigenetics are based on that. And so I have this theory that, what if we all went back to where our ancestors grew up? Would we be healthier for it? And then I thought, well, we have, westernized civilization now, so it may not really work.
Yeah.
But just kind of that concept of returning to our roots. I think that in a really broad sense, that is what health is all about. And I think that could really help improve overall mortality for all of us.
Oh my gosh. I love both of those answers so much. It really is like, there is no straightforward answer, but then at the same time, you can make it so simplistic that there is a great answer. That I love both of those. And that's kind of the reason why I posed this question. It's, I was actually talking to Dr. Ron yesterday, and we were talking about, we're on the forefront of metabolic health and really trying to help the mass majority of our population here who struggles from metabolic syndrome, and how you go back 100 years ago and people were, farmers, especially this part of the country, a lot of farmers who were out from before sun up until sundown, And I mean, they're eating fatty foods. They're, doing a lot of things that we, over the past couple of decades, have said, wagged our finger at, and like, that's not healthy, but also the lifestyle has changed completely. So going back to the roots and eating from the land that you're cultivating yourself, the animals that you're raising, and drinking the milk from those cows, or eating the meat that you raise, you didn't see the rate of heart attacks back then that you see now. So I agree with you as far as kind of going back to your roots. But then I also agree with Dr. Dunn here, where there is no one specific thing, because, you could have, and I don't remember which one of you said it, but you could have identical people. So let's just take, for just simplicity's sake, 37-year-old male, Caucasian, identical backgrounds, heck, maybe they're even related, so they share a lot of genetics and everything, identical cancers, but they could be rooted from very different causes. That is just one of those things where it shows there's so many factors out there, you cannot account for everything.
Right.
So kind of jumping off of that, because again, it's a teaser question. And I think you both answered that beautifully. I am actually very impressed. So thank you. I want to jump into the trends. Last time we talked a little bit about how, with the advent of social media, just the accessibility of the internet, we have it in our pocket all the time. And so many, anybody can go online and make an assertion that, oh, do this, you'll be healthier. Oh, don't eat this food because of X, Y, and Z. Trends are everywhere. So I wanted to kind of get into a little bit more cancer-specific trends that we're seeing, some biohacking that you maybe want to call it, and just kind of do like a little bit of a rapid fire with a little bit of explanation here of take it or leave it. Okay? Yeah. All right. So diet is huge. And I kind of broke up diet into multiple facets here, because Kirsten, like you said earlier, is like, is this diet or that diet better for this cancer or that cancer? But what is your opinion on fasting, Kirsten? Let's start there. Fasting is a whole different topic in general. So intermittent fasting, longer fasts, ultimately just bird's eye view, what is your opinion of fasting?
So blanket answer, yes. Yes to fasting. I think intermittent fasting is incredible. I think that we all need to be intermittent fasting for a period of the day. For a long time, and what we typically say is 13 hours a night, with that key being 3 hours between finishing dinner and bedtime. There's some new studies coming out saying that 16 hours might actually be ideal, which means that you would have an 8-hour eating window. I think that's doable for most of us. And I think we need to give our body the chance to perform autophagy and to get away from metabolization and just to rest and repair. There's stuff out there about longer fast, so water fasting.
Yeah.
I think that that's where it can get a little dicey. I would say yes to those if you have a BMI over 25, if you're weight training, if you are eating adequate protein, then it's probably okay. But I also think that if you're really going to do a water fast, there are centers, and Dr. And I think there's one in Arizona, if I'm not mistaken, but they do like a week water fast. But they're supervised, and they're with doctors. So
when you say water fast, nothing but water for we're talking just multiple days, or how long?
Multiple days.
Man.
And I think that, again, it depends on the person, and we can fall into algorithms again. And I've seen patients go, well, I'm just going to fast to get rid of my cancer.
Yeah.
And it's not that easy.
No.
So
now you brought up a concept here. Can you explain autophagy?
Autophagy is cells doing what they need to do to either repair or to die. Yeah. So it's basically cleaning house.
Yes. Oh, I love that. Cleaning house.
So it's getting rid of the trash that could start the fire.
There you go. Keep going. Keep building on that analogy.
Perfect. And then fasting, yes during chemo. So there's some great data regarding intermittent fasting during chemotherapy. Really? And there's specifics to that, but it's something that I know that Dr. Dunn and I speak to most of our patients about.
Awesome.
Not everyone, but most. Yeah.
Dr. Dunn, what do you have to add to that? Anything on fasting?
I have nothing to add. I agree completely. Yeah, I think I love intermittent fasting, and I agree with the kind of the criteria when you're thinking about doing longer fasts, and I haven't seen really I have had patients go to some of those clinics and maybe they just weren't the best, that wasn't the best option for them at those times. But I haven't seen, a lot of great results from those longer, just water only fasts. But I am a fan of intermittent fasting, or maybe some shorter, longer fasts as well. But no, I have nothing to add. I think I completely agree with Dr. West.
And is that across the board for pretty much all kinds of cancers? Or is it just in general health? Like, what do you?
Intermittent fasting?
Just fasting in general. I mean, is there different strategies?
Overall health, intermittent fasting is something that all of us should practice.
Yeah.
I love that.
In a 13-hour, yeah. I mean, and again, it's maybe some emerging data saying that, maybe longer would be even better. But 13 hours is pretty easy to do.
Yeah.
Most everyone can do a 13-hour overnight fast. Yeah.
So, Dr. Dunn, let's stay with you. What about juicing? There's so many different juicing trends out there. It's cleanses and celery juice only and all sorts of different kinds of juicing ways you can go about it. But juicing in general, what's your opinion?
Yeah. I'm not a huge fan of juicing. I think oftentimes people are juicing a lot of carrots and beets and apples and things that have a lot of sugar. And when you juice it, you're removing all the fiber that helps, if you eat a carrot or eat an apple, that fiber helps to regulate that blood sugar spike from the fruit, or the vegetable, but juicing it removes all the fiber. So it just shoots your blood sugar right up. And you see that. I mean, I think Dr. West could probably attest to this as well. Like, when somebody's come in, juicing a lot of carrots and apples and beets, and before you even see their labs that their IGF-1 is going to be off the charts, and some of these blood sugar markers that we look at are going to be elevated. So I'm okay with doing a little bit of juice, like a green juice or something with lots of green veggies, because it's an easy way to get a lot of those veggies in one sitting. But you just have to be really careful with how much you're drinking, and then what you're adding to the juice. People can come in drinking they kind of go off the deep end with it, and so they're drinking 64 ounces of carrot juice a day or something. It's just too much.
Yeah. No, I agree with that. I think modulating the quantity of what you do in anything is probably a good idea, actually. So, Dr. West, anything you want to add about juicing?
No, I completely agree. I think that green juicing, like Dr. Dunn said, may be okay, but it's got to be greens, and green apples don't count. Right. So parsley, kale, broccoli sprout, things like that, celery. And then I tell them, because I have some patients who are so set on juicing, and I'm like, do your green juice, but do it before or after exercise. Yeah. Because that way you'll utilize that blood sugar right away.
Yeah. And I think that goes back to the basics we speak a lot of here at Riordan Clinic, because, our backbone is IVC and the research that was done here in the 90s. And what that has shown is cancer cells will upregulate the glucose transporters on the outside of the cells like 40 to 50 times, because they have moved over to the glycolytic pathway to make energy, meaning they are dependent on that glucose. Right. So to your point, if you're drinking a ton of sugar throughout the day, you're getting a lot of nutrients, but you're also removing the fiber. So then your blood sugar spikes and you're just fueling that cancer. Right. It's kind of counterintuitive, really. So,
and it's hard for patients to understand too that, celery juice is sugar.
Yeah.
Because they say, but it can't. And I said, well, go to Whole Foods or go to a natural health food store, pull a celery juice off the shelf, look at the label, and it is just sugar.
Yeah.
And then I get, but I'm doing it myself at home. And I'm like, but it doesn't matter. It's still celery juice, right? Like it's still, when you take the fiber out, you're left with sugar.
Yeah. But celery is not sweet.
Right.
It's
calories when I eat celery, right?
Yeah. So it's all about how things are broken down biochemically. It's so much organic chemistry. It really is. So on the topic, Dr. West, we'll stick with you for right now. Kind of a broader question, but are there any... how do I want to phrase this? Are there any restrictive diets that are good and which ones are bad? The ones that you see trendy wise.
A big question. I think that there are several restricted diets that can be therapeutic at given times. I think for some people, ketogenic diet can be absolutely incredible. It has to be done correctly though. And if we're having a nutritionist on board, you have to count macros. It gets confused a lot with the Atkins diet, which is very different. Yes. And then there's the carnivore diet that came out, and the carnivore diet is very interesting. Yeah. And I think that can actually be therapeutic for people who have GI issues. But again, doing it at certain periods of time. I will never probably be a fan of a raw vegan diet. I haven't seen good come from that for patients. I do love my hands down favorite diet when I start with somebody, and I don't know if I like the word diet, but food intake is a low carb Mediterranean diet because of all the nutrients you're getting. It will pretty much work for anybody, regardless of epigenetics or regardless of the status of their gut or their muscle mass or things like that. So,
and that's research based too. The Mediterranean diet has been, oh my gosh, it is the healthiest diet in the world is really what it comes down to. But then when you
any chronic disease,
and then it's when you do the low carb aspect of it. I mean, you don't have like a high carb index. The glycemic index is lower, so it's it's one that I recommend to pretty much any of my patients, since I see more of the complex chronic disease side of things, which is usually driven by a lot of inflammation and uncontrolled factors therein. Right. So, Dr. Dunn, I mean, what's your opinion about the different kinds of diets, and are there ones that are better than the others?
Yeah, I mean, I agree that I usually recommend kind of a low carb Mediterranean diet. Again, you know, we look at people individually, and all of the labs will kind of dictate how we want to, you know, change that a little bit for each individual patient. But, you know, those trends on the far end, you know, the carnivore versus like a raw vegan. Again, you know, I mean, if you're carnivore, you're missing out on so many key nutrients, phytonutrients that help you fight cancer. You know, the fiber that you need for your gut. You know,
yes,
it's like, so it's just and then, you know, when it's raw vegan, you're missing so much protein and healthy fats, and just so I mean, I think that those extreme diets are devoid of nutrients that we need for health and to help your body fight the cancer. So I mean, there are moments when you will veer more towards one or the other, depending on their physical state or what their labs may show us in, you know, in any given time. But in general, I'm not into either extreme.
Middle road for sure.
Well, and I always tell people eat for the raw vegan. I'm like, well, we're not cows. We don't have 4 stomachs, right? We can't eat like just grass all the time. Right. And the carnivore and keto are therapies. That's how we have to think of them. They are therapies. They have to be done correctly. Carnivore is not just eating chicken breast and bacon. You know, it's like you have to eat the entire animal, which includes liver. It includes eyes. It includes, you know, it's the whole animal, because you have to get all of the amino acids.
Yeah.
So just like keto, it has to be done correctly.
And it's a lot of that stuff, like you said, eating the different animal organs have the different nutrients in them, and that's the only way that you can get some like rounded out nutritional profile from the carnivore diet, and a lot of that's not palatable. So I think everybody thinks they can go eat steak for every meal. I'm like, that's not how this works.
That's exactly what I think.
Well, and there's like internet keto, which is like bacon and butter, and it's like, no, we can do this better. So,
no, I love that. And then pairing the tool of carnivore or keto or whatever it may be with a nutritionist who has the education, the background to be able to talk you through it, I think is really important too. Because again, going back to knowledge is power, right? So kind of shifting gears from the diet aspects of things, there's a lot of repurposed medications as far as the pharmaceuticals go. And one of the biggest ones that we're seeing right now is like a fenbendazole and ivermectin phase, where you can go online and you can essentially buy it yourself. But I think a lot of people are missing the fact that there's been a lot of research on these different drugs as well. So I wanted to get your opinion. specifically on this, and then we'll kind of open it up to any other repurposed medications here. But Dr. Dunn, I mean, what's your opinion about the Finben ivermectin craze?
Yeah, I mean, I think that there's probably a lot more hype than substance, on the internet. I think this is, something that we've utilized for the last few years. I think there are some interesting, cell studies on them. I think, a few interesting case reports. I think there's probably a lot of inaccurate maybe case reports out there as well. And so I think there's a lot of misinformation surrounding these drugs. I wish they were a cure-all. I wish they would cure everyone's cancer. That's not what we're seeing. That's not the case. And I think, again, it comes back to individualization and all of these trendy things. Like, I'm sure that there are some cases out there, but if it could cure everyone, that's what we would be doing. I'm not trying to gatekeep some magical cure from a patient. Like, if I have seen it work, then I'm going to be, I would use it, but it's just not. And it's not what we see in clinical practice. It's not like we're not seeing people cured from ivermectin and fenbendazole. And I think it's also when people are reading these cases online to keep in mind that you don't know the person, you don't know why they're promoting it, you don't know what they're gaining from it. It may just be a presence online, it may be, who knows, and also sometimes people have great benefit and they don't share the full story, right?
Yeah.
So we've had patients that, have, and literally I've had a patient that, in Oregon that, told everyone that they were cured by a particular remedy. And in reality, I knew that they had had full treatment, like they had had all the traditional things, but they don't bother to share that when they're telling everyone they were cured by this natural remedy. And so I think there could be a lot of that happening online right now with this particular combination. But I mean, I think that there are a lot of one-offs. I think there are miracles. I think there are things that can help, any patient, but if it were consistently curing people, that we would have seen it. And unfortunately, that's not what we're seeing.
Yeah. Dr. West.
Totally agree. I think off-label drugs are sexy.
Yeah.
I think it's easy for patients to be like, oh, here's that one thing that's going to work to cure me. Mm-hmm. And it's just not that easy. And I completely agree with what Dr. Dunn said. There are case reports of people who say that these things cured them, but I know several where there was so much more that was done alongside these drugs. And granted, some of the animal studies are very promising with ivermectin, but these animals are taking amounts of ivermectin that no human being can metabolize without having major neurological side effects.
Blindness.
So
yeah.
So I think, as with anything, as we talk about cancer being multifaceted, these drugs may be beneficial in that way if we use them in combination and we're harmonizing our treatments and our therapies. Mm-hmm. Then they may be very beneficial.
So are there any other pharmaceuticals, like existing pharmaceuticals, that could be utilized off-label that can help with cancer treatment?
I know that Dr. Dunn and I recently have been, the GLP-1s are coming out now, and using these in low dosing, not the typical, but I think that doing a little bit, like microdosing of these may be helpful, and not for everybody, but for some patients. Mm-hmm. We're seeing promising effects. Now, granted, also, these are fairly new, so we don't have a lot of the longer term studies, but what we are seeing is pretty promising, and it makes a lot of sense from the metabolic pathways and paradigm of cancer. Metformin's been out for a very long time. The only issue with metformin is that it can really affect methylation pathways. If you've got somebody who has like folic acid issues or B12 issues, you may be doing a physiological disservice to that patient if we're not looking at the full picture. Things like aspirin, celecoxib. I mean, there's numerous things where if they're used intelligently, not just blanket, this is your algorithm of off-label drugs to use, I do think that they can be beneficial.
So you need to have a strong base knowledge and education in biochemistry, pharmacology. So you need to understand the individuality of each co-learner /patient. So yeah, being able to see through that, I mean, that's what we do as physicians. And I think I feel like there's so much information out there that the water gets muddied quickly.
Yeah.
And I love, Stacy, what you said about, like, I'm not gatekeeping a cure here. Like, I'm not benefiting on not giving something to anybody.
Right.
You know, I got this all the time when I was working ICU and COVID even. And it was just like, okay, yeah, let me make my life harder by not curing people.
Right.
That's not how this works. But the problem is,
Job security.
no, it's just, yeah. And it's like, and I know I'm kind of going off on a tangent right now and everything, but the whole point is, you know, we all became physicians, whether it's MD, DO, ND. We all got into healthcare because we want to help people. You know, we're fascinated by the science, but we ultimately want people to enjoy a healthy, like, high quality life, right?
Yeah.
I don't want to hold this back. And I'm not getting any kickback from not giving any meds to anybody. So it's just kind of like, okay, so yeah, it's a difficult area to be in.
Mm-hmm.
So, and jumping off of that, I kind of want to skip ahead here just for the sake of time and everything too, because I have a couple of the questions here at the end that I think are really important to hit. First off, do either of you think that there's any popular cancer wellness trend that you think is overhyped? You kind of maybe have already touched on it, but what is overhyped in your opinion? Dr. Dunn, let's start with you.
Oh boy.
Everything we just talked about.
Yeah, I mean, I think that there's just not one treatment. So if one treatment's being, hyped as the cure, this is the cure for cancer, and so it's often these days ivermectin or Fenbid, then it's overhyped. I think right now in this moment, that is what is being overhyped. Yeah,
it is a lot. I mean, it's everywhere. If you just go to Google, man, it's right there, and they've got pathways for you to go buy it.
Yeah.
So, Dr. West, anything that come to mind for you for as far as trends that you've seen that you just think is overhyped?
Juicing carrots. I think number one forever in my life, that will be it.
Okay.
Carrot juicing.
That's fair.
So,
and I mean, all the reasons why we already talked about, like you're missing out on the fiber, you're missing out on all the other nutrients, and you're spiking blood sugars, you're feeding the tumor.
Right.
It's crazy, you guys, and I know that you guys know this, but carrots have a higher glycemic index than ice cream.
Yeah.
So
that's insane.
Even juice them, and then I get patients where I go, well, can I have ice cream then? And I'm like, no, that's not the point. Like, the point is, we shouldn't juice carrots. So
it's like, listen, if you're not under that therapeutic diet we talked about, live your life in moderation, right?
Yes.
So one scoop of ice cream might be a mental health break. You're fine. That's okay. But no.
Exactly.
So to kind of wrap all of this up, this last question, I really speak to the co-learners. I really want to kind of hear it from your own words, but how do you navigate this emotional tension between honoring the patient autonomy, but then also protecting them from the harmful decisions that might be out there that they're not aware of? So let's start with Dr. West.
I think, again, it's about meeting the patient where they are. And if there is something that someone is completely set on, and if they feel as long as it's not going to harm, well, it really is. If it's not going to harm them, but it's something that they want to try, I'm willing to monitor. Mm-hmm. And see how that goes for them. And I will always, always, always tell them what I would do if it were myself, if it were my sister, if it were my mother, if it were a close family member. I think that is the most important, because my job is to guide them towards health. And I don't want anything they're doing to be a barrier to that. Sometimes patients do have an intuition about something that is really right for them. And while I may not agree with it, it may be helpful. So I think it's just really navigating the course as we walk together as patient-doctor relationship. But if it is something that is going to harm them, I'm going to tell them not to. I'm going to tell them not to do it.
Right. And I think you also said something there that's incredibly important, is walk this together, because we as physicians cannot accurately treat you and guide you unless we know everything that you're doing.
Yes.
This is something where we really try to come at it from a unbiased area. We might have some education or some knowledge on things, and we might try to guide you away from something that might harm you. And it's not just because, oh, I don't like that because I don't get money from them. Again, we're not getting kickbacks. That's not how this works. But, having that autonomy and the patient's deciding to do something like it maybe ivermectin and Finbin, right? Fine. Let's talk about it. Let's see how that fits in. This is my opinion of it. I recommend not, but if you continue to do so, just please let me know, Well,
and I think a big part of this, which is important to speak to, is that if they are doing standard of care therapies and it's something that's going to compromise what they are doing there,
Right.
then that needs to be discussed.
Yeah.
That is a big issue, especially if the intent is cure.
Yeah.
Because we don't want to create a goal towards cure.
Right. And you could end up working against yourselves. It's just,
Right.
yeah. So Dr. Dunn, your opinion, how do you walk that line?
Yeah. No, I mean, I agree. I think you share your what you would recommend based on, based on my experience, based on what I've heard from them, what I've seen in the labs, I'll share what I think we should do, but I always want to hear what they think, and I want to hear what's guiding them. As long as it won't interfere with the treatment, as long as it, won't harm them, then I'm happy to incorporate other therapies as well. I agree with that intuition, but I also agree that there's a lot of misinformation out there, and discussing it and listening to why they want to try this. Is it because their uncle's brother recommended or whatever? Where are they getting the information and what's driving it? And then but I want to honor what whatever is guiding them as well,
right?
As long as it's safe, and I, we have a lot of experience. So we've seen these things come and go. I mean, in integrative oncology, there's always trendy things going on, and so it's like, whatever it is this year, it's like we've seen things that have worked and things that don't work, and so we can share that experience with them, and that's all we can do. I mean, it's ultimately their decision, and I'll support them whatever they decide. Yeah.
That's amazing. I love that. That's actually what medicine really is. It's not the core root of the word physician actually means teacher. It's not like, medicine man or whatever it may be. It's literally, we're trying to take what we've learned and what we've experienced with others and try to impart that knowledge on everyone else. So
because I don't claim to be all knowing. I don't know everything, that may work for the patient, but I do have a lot of experience that I've seen a lot.
Yeah. I don't know is an answer. I always told that to my students. I've always told that to my residents when I was in residency as well. When I was chief, it's just like, it's okay to say, I don't know, or I'll look it up,
Yeah.
So when we have that conversation and we call our patients co-learners for a reason, it's because quite literally we're learning too. And we're trying to bring the actual research into it to explain that this is how it's been studied and this is why we don't recommend it, or this is why we do recommend something. So I think bringing it back to the basics, Kirsten, like you said, I think is a beautiful idea. In the society that we live in now, we are absolutely living in the weeds. We have to navigate this, and navigating it together is how we win. So, ladies, as always, thank you so much. This is such an easy way to have a conversation with you all, to be able to involve our viewers and our listeners with the podcast here. I want this roundtable to only grow. And if we have any recommendations or have things that people want us to talk about or explore, please feel free to leave comments on the YouTube or the Instagram channel. I have actually tried to go through and see if there's any recommendations, but time flies when I'm with you. We've been on for over 30 minutes. Come on. All right. Well, with that said, thank you for another episode of the Riordan Roundtable. We will see you guys next month.
Thank you.
Thank you for listening to the Real Health Podcast. If you enjoyed this episode, be sure to subscribe and leave us a review. You can also find all of the episodes and show notes over at realhealthpodcast.org. Also, be sure to visit riordanclinic.org, where you will find hundreds of videos and articles to help you create your own version of real health.